Hello, good afternoon. On behalf of Konica Minolta Healthcare and the Shimatsu team, Medical Systems, I want to welcome you to RSNA 2021. We're all excited to be back here. It's great to see you in person. We appreciate it. I think it's really great. So today I'm Guillermo Sander. I work for Konica Minolta in marketing. It's my great pleasure to introduce Dr. Satinder Singh, who's going to give us his initial impressions on Dynamic Digital Radiography, DDR for short. So Dr. Singh completed his radiology residency at the All India Institute of Medical Sciences in New Delhi, and subsequently at the University of Alabama at Birmingham. He liked it so much, he stayed and completed his cardiopulmonary radiology and thoracic MRI fellowship, and he serves as the director of cardiac CT, chief of cardiopulmonary radiology, CT modality chief, and director of the combined cardiopulmonary and abdominal imaging fellowship programs in the Department of Radiology. He has authored over 100 articles, book chapters, abstracts in radiology. His research interests include CT, dynamic airway imaging, and neoplastic and inflammatory conditions of the lung and pleura. And he's also very patient as he explains all these terms that I can hardly pronounce to me as a marketing person. And I'm really grateful to have him here and to know him. So, Dr. Singh, please.
Thank you very much. Thank you, and happy to see a lot of people around. All right, so this is a topic which is kind of new to me. We just acquired this technology a few months ago. And the first time I saw the image which is playing in the background, it was just wow. You know, this is what everybody who has not seen it, when you see it, it's just like a Harry Potter movie, right? When we open the newspaper, there are moving subjects. So we started in late May or June, and then up to November, we were still kind of, optimizing what we need to scan. Initially, we said every patient who comes, let's scan it. Then we narrowed down a little bit to few areas. But one thing which we narrowed down is looking at the diaphragm, because we were doing a lot of chest fluoroscopy, and I thought, this is a good modality to compare and ultimately replace the regular chest fluoroscopy. So a lot of people were involved in procedure, and I would like to acknowledge many of them. Lindsay Catt, who is the outpatient lead technologist, Jeff McGoey is the outpatient director, and there are several of our departments, my colleagues in chest radiology, some of them are here. John Sobel, PhD from Konica Shimatsu, who is not here because of the illness. He helped me a lot, and my son, Nicky Singh. Because yesterday, I got one video which I could not play or download, so I texted him, I need help, and sent him, the video. 5 minutes later, I got back, help provided. So I got the video, and it's working. So the objective of this talk is to discuss the technology behind dynamic digital radiography, describe my initial impression on its initial clinical use in thoracic imaging with case presentations, and the initial experience and research results comparing the DDR to conventional fluoroscopy, which we did at the University of Alabama, looking at the diaphragmatic function. And finally, potential futures of this technology and research opportunities. We will look at few aspects of that. So as a background, we know the X-rays was discovered in December of 1895, and immediately after that, chest imaging was the first thing people started looking at the tuberculosis, spots on the dark gray images. And since then, chest radiography has improved, and it still remains the mainstay of chest imaging despite significant advances in cross-sectional imaging. Its main advantage is the speed at which we can acquire it and we can interpret it, and it is a low cost and low radiation exposure. So any patient, whether outpatient setting or inpatient, any patient who have symptoms in chest diseases or otherwise preoperative evaluation, they get chest radiographs. And portable chest radiography remains the main tool to monitor ICU patients, and approximately 30 to 40% of all X-rays done in any department are chest radiographs. So despite all these advances, we were still not there till we saw these images. So dynamic digital imaging is basically you are evaluating or looking at the images which are moving. Patient is free breathing during the image acquisition. This allows not only the anatomic but also physiologic changes over time when you look at the entire lung over the respiratory and cardiac cycles. And it can also improve the quality and specificity of diagnosis. If you're suspicious on static images, but once we see the rapidly moving chest radiographs, it can help you exclude or include a pathology. So briefly, what it is, it uses a sequential pulsed X-ray production from the machine, and then it goes through the patient at a distance of 2 meters from source to the plate. We have a flat panel detector which takes the images and then we process it downward. So this is a kind of complicated diagram here. So when the hand switch is on, when you're taking the patient, there is the auto voice which was there. You can always modify it. And you keep pressing the hand switch for 20 seconds if that's your complete 20-second exposure. And you let the hand switch off at the end of 20 seconds. And in between, the voice will be there, whether it is auto voice or you can record it, giving different instructions regarding breathing. What we started was just tidal breathing, just breathe normally, you know. And when we are looking at the diaphragm, we will ask the patient to sniff in between and then go from there. So basically, pulse images, X-rays come from the generator, pass through the diaphragm, go to the flat panel detector. And this is a small video showing how it is done. It's a standard PA view, right? The X-ray source is here, the plate is in the front. And the technologists keep pressing the on button. So there are instructions by auto voice, you know, to keep breathing. Once it is done, the technologist will let it go after whatever assigned period of time it is. And then you got the images. Now, this is an extra step here in DDR. Rather than images, once they are acquired, go directly to PACS, they have to go through a computer for post-processing. So there is some extra time which is required in between these two, which can be sometimes little troublesome if you have a very busy practice. So we have assigned, you know, if you are too busy, go ahead and, you know, send patients to the regular unit 2 and then do some cases on this. It generates almost 300 images over a period of 20 seconds. So that's why this takes little time to make them in a cine loop to play for you on eyesight. But once it's done, you will get all the images. You will get a static PA lateral and the image with the motion, and then there are post-processed images. Now, post-processing can be a lot of things. You can either remove the bones, just like a dual energy radiograph, but you have the movement, and you can look at the, you know, nodule in the right lung very clearly. Or you can edge enhance it. It's called frequency enhancement, where you can look at the bones and the sharp edges around the diaphragm and the cardiac silhouette. I think this image is maybe useful for looking at lines and tubes. You know, we have currently a sharper filter for those techniques. So these are the post-processing initial 2 images, but then you can do further evaluation. Now, changes in the pixel value of the lung is caused by differences in the X-ray transparency. So the lung density, when patient is breathing in and out, it changes. Anytime you breathe in, there is less attenuation of the X-rays, so lungs are black. When you breathe out, there is more density, it becomes more whiter. Similarly, during the cardiac cycle, when it's in the systole, there's more blood which is pumped to the lungs, so lung images are slightly whiter as compared to diastole. But these changes are not visible on a naked eye, so you cannot really determine what's going on. So that is why you have to have these images post-processed to look at the ventilation. Then you will can assign the color to look at the images. So when the patient has taken a deep breath, both the lungs are filled with this color. So if there is some kind of focal abnormality in the airflow, you might be able to detect it. Similarly, in the airflow, this is the patient who is not taking a deep breath. Similar color mapping will be to the entire lung. So we can see if there is any kind of vascular issue, there will be deficiency of that color. So I think this is the area of research which have a lot of potential with a very simple technique. Remember, this is just from chest radiographs, nothing else. Now, radiation dose, everything, any new technology comes, first thing is radiation dose. When the cardiac CT came, a lot of papers, oh, you're going to kill the people with radiations. And there is a new logo for the IAEI, right? It was initially this. Now, you take too much radiation, this is what happened. So run away. But is it really bad? This is a magazine clip from 1898, where you can see X-ray exposure was used for antidote for headache. It's quick, it's safe, and it's sure. So, they were pretty good at looking at these X-rays used. And this is a really great idea by looking at the shoe fitting testing. So ladies, come and put their feet with the shoe inside. They can watch through this tube here, and the person who is fitting the tube look into that and take a lot of measurements. And you wiggle your toes and find out whether it fits or not. There's an issue. Radiation can go up to 50 millisieverts, no problem. It's just you are getting a good shoe fitting. So I'm not sure whether Dr. Soul has seen this or not. it might put him to bankruptcy. Now, looking at the radiation doses, this is kind of a limited evaluation at our university. We looked at standard PA, PA lateral, and DDR, and the average fluoroscopy. The doses for PA lateral are around 0.59, or the relative dose is 0.33, but for DDR, I think it was 3 times more than a regular PA and lateral radiograph. At least this is what we found. But I think there's a lot of potential. We can tweak the technique to decrease the radiation dose further. Okay, you can decrease the kV, you can decrease the exposure time, among several other things. But look at the average fluoroscopy. We know fluoroscopy is quite operator dependent. Many of you might have seen your residents. You tell them to put an NG tube. First thing they do is start fluoroscopy, and then they talk in the patient. I said, oh man, took the fluoroscopy foot out of fluoroscopy. I mean, you will really burn the patient. So this dose was relatively higher because this was done by relatively not very experienced people, but I think this has given us a chance to improve and teach those people that what we are doing is exposing the patient. But look at the dose as compared to the radiography DDR. It is 10 times less. So if you can achieve, looking at the diaphragm from DDR, just routine DDR, I think this is fantastic. Not only dose reduction, we can see a lot of other things which we would not see with fluoroscopy. So here are some clinical examples. So examples are mainly in the pulmonary medicine, looking at the structural abnormalities, whether they are suspected nodule or any focal abnormality, or even in the post-operative cases when there are adhesions which can help for that procedure, or looking at the thoracic cage dynamics after thoracic or cardiac surgery, because that can lead to a lot of debility, morbidity after the surgery. And of course, diaphragm function, this is where we concentrated initially. And also resident teaching. This is a very good tool to teach the residents. What we found lately is residents are great in cross-sectional imaging. When it comes to chest radiography, they don't know much. They don't know physiology, how it works, what is what. So I think this is a great way of looking at the physiology in the different degree of inspiration, expiration, as well as during the cardiac systole, to teach them how these changes look different in different phases. And of course, there is a good chance that we can collaborate or correlate with pulmonary function studies and can do somewhat similar with DDR. And this will be actually very useful in pandemic where you don't want patient contact. So this can be remotely done, and you can evaluate at least approximate numbers, because you can give instructions to take deep breath, forcefully exhale, so you can get all the PFD data which you can get from spirometry. And of course, ventilation and perfusion, once they are mature, I think they will have a lot of utility and functions. And of course, second big group is orthopedics, which I don't really care much. So here is a first patient, heart transplant. We do radiographs, screening radiographs on these patients, looking for any abnormality because these are immunosuppressed patients. So regardless whether they're symptomatic or not, they get radiographs, P and lateral, and also get their cardiac catheterization with endomyocardial biopsies. And we are on a radiograph looking for radiographic appearances for the rejection of the transplant, which is in the form of heart failure or enlargement of the cardiac silhouette. And also for opportunistic infection, they usually present as nodules or consolidation, and also PTLD, proliferative lymphoproliferative disease, which can often present as nodules or masses. So this patient has a tiny abnormality here, as noted, very faint, seen on only the frontal PA view, but not on the lateral view. This patient was still in the clinic, so we called him back. This was a regular dual energy scan or radiograph. We called him back, and we said, let's do a DDR, just to confirm. And on the DDR, you can see, this is a subtracted image, that nodular density persists, and I zoomed it up. It's kind of blurry, but you can see a vessel going through it, but there is a persistent abnormality. So our suspicion was a little more stronger. So we said, this was not present before, so we need to investigate further. So this patient ended up having a non-contrast CT of the chest, which showed that this abnormality was actually along the pleura in the posterior rib, right there. Patient also has similar changes on the other side, but we could not see. So we are seeing this because they are projected longitudinally in front of you. So you can see only on the frontal view, but on the lateral, because the density is lower, you cannot really have the density evaluation on lateral view. Same thing is happening on the other side, where the density is parallel to the posterior costal pleura, so you cannot really see on the frontal view. So it's all radiographic imagination, but it can help you. But this finding is not suggestive of PTLD, so this patient basically need follow-up because he's not symptomatic. Here is another patient. Radiograph shows this patient has interstitial lung disease. It shows this focal abnormality along the left lower cardiac margin, which is silhouetting the left hemidiaphragm, left cardiac border. So we are not sure what exactly it is. So this patient also was having a sniff testing, and CT was done, just baseline, not based on our finding, and we saw that this finding, in addition to the ILD, is basically extra fat. You can see better on the coronal right here. And because it is kind of retracted from fibrosis, it is abutting the cardiac pleura and not silhouetting the diaphragm. It looks like a focal opacity, but it's nothing, it's epicardial fat pad. So it can help. Similar findings of airspace disease elsewhere. Now, nipple shadow, we know if it is bilateral symmetrical, we know from radiograph we don't have to do anything further. But if they are unilateral and you are doing a metastatic patient with known cancer, you really want to make sure. So traditionally, you will do a nipple marker study, right? But now if you can do a DDR, you can clearly see these nodular densities are not moving. They are outside the chest wall, on the chest wall, not inside the lung. So if you start with DDR, really there is no point in doing any extra studies. The postoperative evaluation, this is taken from one of the Japanese hospital, a patient with right upper lung cancer. This is the frequency enhanced scan. You can see the nodule, how differently it appears on inspiration and expiration. On expiration, it almost overlaps the costal cartilage and can be missed. This is one of the area where a lot of lawsuits happen for chest radiology. So this can be very useful. And after the surgery, 1 week after the surgery, you can clearly see the patient has a large free pneumothorax as well as hydropneumothorax. This is the airflow level in the inferior basal pleural space. And the diaphragm is not moving well, but after 1 month, you can see the diaphragm is moving well. These are the post-surgical changes from the right upper lobectomy. So post-operatively, I think it can help you decide whether any complications which are they are progressing or decreasing. Now diaphragm, we can track the motion of the diaphragm by putting in markers, and we can clearly see the right hemidiaphragm is moving much more as compared to the left side, and you can plot it on a diagram and look at these information. It's dynamic, don't need to do any fluoro. Since we did some work on diaphragm, I'll just emphasize a little more time on the diaphragm. The diaphragm basically has a central tendon, which is this white structure, and then more of the peripheral musculature. It has the posterior attachments and anterior and lateral attachment. Posteriorly, it has two diaphragmatic crura, which we all know or always see on the CT, and they attach to the upper lumbar bodies and anterior vertebral bodies. Then there are lateral and the medial arcuate ligaments, which we also know. Sometimes these arcuate ligaments on CT can look like a nodule, can fool you, and they are important for the function of the diaphragmatic crura. And of course, median arcuate ligament can cause compression of the celiac artery. We know celiac artery syndrome. The anterior and lateral attachments are to the inferior sternum and xiphoid process and inferior left or bilateral sixth ribs and adjacent costal cartilages. The nerve innervation is by the phrenic nerve, C3, 4, 5, and they anteriorly go along the pericardial surface, and then they splay on the superior aspect of the diaphragm bilaterally. And the function of the diaphragm is, it is the primary muscle of ventilation. Okay, when you do meditation or yoga, they tell you to take a deep breath. Your diaphragm is doing most of the work. Of course, there are other muscles, the muscle at the thoracic inlet or the accessory lateral chest wall muscle. So they basically expand the chest wall in all directions, so you can inhale more air in. It also decreases the intrathoracic pressure, which causes increased venous blood flow back to your heart. In addition to the ventilation, it also aids in emesis, urination, defecation. I don't have to tell you, you probably have experienced that when you use this diaphragm. And it also prevents gastroesophageal reflux by exerting external pressure at the esophageal hiatus. So diaphragm dysfunction can be either paralysis, total paralysis, no movement, or it can be weak. It moves, but not normally, or it can be due to a condition called eventuation. It is a congenital anomaly. So diaphragmatic dysfunction is a frequent contributor to shortness of breath or dyspnea, which is a common complication from a lot of diseases in the chest. So let's look at the eventuation. What exactly is eventuation? It's a congenital weakness of the diaphragm where the lateral aspect of the musculature is not developed and it is replaced by a thin membranous sheet. But the diaphragm is there. But over time, this region stretches, and on inspiration, it does not contract normally. In fact, if you do a fluoro, I'll show you the example, it behaves abnormally. So here is the patient with elevated right hemidiaphragm, and on the lateral view, what you see is the anterior portion of the diaphragm is elevated, where the posterior is not. This is a case of partial eventuation, which is more common than complete eventuation, where entire diaphragm is eventuated. Here is the lateral view, and on the CT, you can see the part of the liver, which is protruding inside the chest. Looked like a Watto from the Star Wars, right? This head. So what are the common causes for diaphragm paralysis and weakness? Most common is surgery. Whether it is a cardiac surgery, it's usually more on the left side, because during the cardiac surgery, we do cardioparesis with cold. So initially, those phrenic nerves are injured, they get numb. So initially, there is a temporary elevation of the diaphragm, but that will recover in few days to weeks. But if during surgery the nerve is cut, then it is irreversible. So that will lead to persistent elevation of the left diaphragm over time. And of course, trauma, it can be penetrating injury to either side, or even a blast injury from a significant remote gunshot injury, or sometimes traumatic motor vehicle accident can also cause phrenic nerve injury. The tumors, whether it is primary lung cancer or metastatic disease to the mediastinum or hyla, they can involve phrenic nerve and lead to diaphragmatic paralysis. Infection is a major category. It's almost when we call idiopathic elevation, which we don't have. Usually it is infection. But in addition to regular viral infection, patients who have shingle or Lyme disease or even Guillain-Barré, they can involve the phrenic nerve, and even diabetic metabolic acidosis can also affect the phrenic nerves. And if the patient has prior radiation treatment, for example, Hodgkin lymphoma or breast cancer in the upper mediastinum, that can lead to injury due to fibrosis to the phrenic nerve. Now, diaphragm dysfunction sign and symptoms, they are variable. It can be dyspnea, decreased exercise performance, sleep disorder symptom, hypersomnia, etc. If it is bilateral, it is worse as compared to unilateral. And these symptoms are worse in supine position because in supine diaphragm is already elevated, so it cannot exert function properly. And in submerged position, so patients who go to swimming, when they submerge in the water, they said their symptoms become more apparent. And once you do the PFTs, they are mostly restrictive, again, worse with the bilateral and worse with in supine position as compared to erect. So indication of sniff testing, which we do at UAB, all pre-lung transplant patients undergo sniff testing. And if there is a clinical evidence of diaphragmatic dysfunction, whether it is elevated hemidiaphragm or unexplained shortness of breath, or symptoms while lying supine or in the water, or associated comorbidities of heart, lung, or obesity, or new exercise limitations. So these cases do end up, we are excluding different etiologies, so diaphragm is one of the causes for these dysfunctions. So when you do sniff test, it can be either normal, there is regular movement of the diaphragm during normal breathing, deep breathing, and sniffing. They both move in same direction. If it is paralyzed, the paralyzed diaphragm will not move, and with sniffing, it will move paradoxically in the wrong direction. And if it is weak, you will see the movement of both diaphragm, but the weak diaphragm don't move that much, and with sniffing, it might show actually paradoxical movement. And this is the tricky part, but if you see paradoxical movement, not every diaphragm is paralyzed. It can be weak. It's still not paralyzed, but you'll show a paradoxical movement. Here are some examples, 54-year-old with chronic interstitial lung disease and pre-lung transplant evaluation. Patient has both emphysema and basilar interstitial lung disease. You can see it here. And we did a DDR, and you can show symmetrical diaphragm movement and no paradoxical movement. This is patient with right hemidiaphragm elevation. It is completely elevated, right hemidiaphragm. It is not the partial diaphragm, and the liver is elevated on the lateral view, on the coronal CT view. And on the conventional imaging, chest fluoroscopy, you can see the sniffing is positive. This paralyzed right diaphragm is going other way when you sniff in as compared to the left side. Here is the sniff testing with the DDR, same finding, the right hemidiaphragm is going up when you take a sniffing compared to the other side. So this can be done with DDR very easily. So what happened with the diaphragmatic eventuation? The eventuation on the right side, this right hemidiaphragm is elevated. With quiet breathing, they both move, but this diaphragm is moving less as compared to the other side. So this is not totally paralyzed. But when you do the sniffing, you can see this is kind of giving you paradoxical movement. So this is actually not paralyzed diaphragm. This is just a eventuation, a weak diaphragm, which with increased intra-abdominal pressure or sniffing, it cannot do the regular movement which normally can be achieved. But you have to have a lateral view to show this, and you can do the lateral view. Now this is typical Alabama patient, right? The BMI of only 56. And the patient has obstructive sleep apnea, recurrent bronchitis, cough, chronic dyspnea, very elevated right hemidiaphragm. But when you look at the lateral, this is a scout CT images, the anterior portion of the diaphragm is elevated, not the posterior portion. This is obviously what we learn now, this is likely is eventuation, not paralysis. Paralysis does not cause focal paralysis, right? It is all uniform. So we did a regular fluoro examination. Because of her body weight, it's very difficult to see what's going on. But you can see this diaphragm is moving with regular breathing. It does not move that much, but it moves. And here is the DDR image, again showing very clearly the right diaphragm from the left diaphragm is here below her big heart. So they are moving, but does not move that clearly. So the diaphragm was not a problem for heart problems. But what we did was also did a dynamic 4D CT to look at her airways, and what we see is she has severe tracheobronchomalacia, which was causing her symptom. This is a dynamic CT, free breathing during the scanning, and you can look at during expiration, this whole trachea is kind of collapsed. All right, diaphragmatic pacing for spinal cord injury. This is a big, big problem, although the patients are limited population, but very important subject. In diaphragmatic pacing, what we do is we have a lightweight battery-powered system which electrically stimulates the diaphragm muscle and nerves. So basically, this is a generator, and the wires go in or leads go in, and they go on both sides. You can actually control from outside one diaphragm or the other, which way to stimulate. Now the diaphragm pacing, although it is a very trivial thing, but it can tremendously improve the quality of life in these patients. It can reduce or eliminate the time spent on ventilator. These are the quadriplegic patients who have a C-spine injury, C3, 4, 5, transection. So unfortunately, they are ridden to, ventilator or on a wheelchair. You might have seen in the movies, all the time. Pacing can help their breathe, and they may be able to speak normally, increase their mobility and transportation because they are not dependent on the ventilators, and makes their regular day activities more easier, dressing, bathing, and just moving around in the house. Also, once the lungs start moving, the chances of getting infections are decreased, and it also improves the sense of smell and taste because the lungs are getting better. So we had one patient, this is a football player, college football player, who got injured during the game, and he got quadriplegic at C-spine level. And he had a tracheostomy, long-term tracheostomy, and we did a pacing of the diaphragm, and we wanted to see his function of the diaphragm after the pacing. So when we do the DDR with the pacer off, you can see both the diaphragm kind of move, but they are not very aggressively moving. So, but when you look at with the pacing on, these diaphragms show more improvement as compared to the maybe pacing off. It's not dramatic, but still, this can improve with physiotherapy, once you do that, and these patients will be able to improve their day-to-day activities. So this is a brief testing we did comparing the DDR with the chest fluoroscopy. We looked at 19 patients, so 38 hemidiaphragms. We found 6 abnormalities. 3 were severe diaphragmatic weakness, and 3 were eventuation. Unfortunately, there was no paralysis during that period. People knew that we are doing a test, that they did not show up. So what we found was majority of the issues on the diaphragm dysfunction, we were able to look with DDR. And additionally, the DDR was able to show, because it's a large field of view, you can see the entire lung, anything else going in the lung, and hiatus, hernia, etc. So we looked at all of our radiology colleagues, they prefer DDR over chest fluoroscopy. This was only with PA view. This is not lateral, because we did not knew, what's going on. But once we have done this, and we found one case we called weakness, it was eventuation, which we only see on the lateral view. We said we implemented the PA and the lateral sniff testing on these patients, but decreased the exposure to 12 seconds rather than 20, just to reduce the overall radiation. And I think this is what we are going to go forward, January forward, replacing the regular chest fluoroscopy with the DDR. Now for chest fluoroscopy, this is done at our outpatient patient. During COVID, we did not have a person there physically, so we had to go from the hospital to that side to do the chest fluoroscopy. But if you have a DDR, you don't have to do it. They will take the images, you can review on the PACS, and that's it. Resident teaching, this is just basically, brief. You can do all kind of stuff. Look at the lung parenchyma, how it affects the lung bases, this is a sniffing, how it changes the cardiac silhouette during expiration, inspiration, look at the cephalization of blood flow, etc. I mean, a lot of things can be done. One thing in this case, what you see is this prominent upper right cardiac margin, which is usually due to the dilated ascending thoracic aorta. And you can see this become more prominent during systole and expiration. right? And this is a CT of the same patient, very dilated thoracic aorta. So it just increases your specificity, and I think it is very good for teaching. I think there are a lot of options here to teach the physiology of the lung and heart together. Okay, what about the research? We talked about diaphragm motion. This study looked at diaphragm motion in healthy subjects. There are 174 healthy volunteers. They looked at both diaphragm. You can look at the diaphragm by their movement. You can tag it with the dots here or put a lines here. What they found was average excursion of the diaphragm and peak motion speed measured was higher on the left side in the healthy normal population. And if the patient has a large BMI or their vital capacity is higher, they are associated with higher excursion and faster speed, which you can plot them in these diagrams. Looking at the right hemidiaphragm is red and blue is the left hemidiaphragm, both higher excursion and higher speed. This is healthy population. What about in COPD? This group looked at small group of patients in COPD. What they found was that COPD patients during tidal breathing, regular breathing, their diaphragm excursion is higher as compared to healthier. And left is still move more than right. But when you tell them to forcefully do the breathing, their excursion and speed of motion is decreased. Not with tidal, but with forceful. So what is the clinical implication? Clinical implication is larger diaphragmatic motion occurs during resting to compensate for hypoxia due to less gas ventilation exchange in the rest of the COPD lung. And that leads to, because the diaphragm is working more, it leads to respiratory fatigue during day-to-day life. And if you tell these patients to walk a little bit or do some exercise, they get worse because now their diaphragms are not even moving that much, so they get short of breath very quickly. So this is an objective way of looking at why the COPD symptoms are occurring in these patients. We can also look at air trapping in COPD patients. This is a paper which looked at 118 patients with airflow limitations. They looked at the relationship between the lung area and the rate of change of lung during the maximal inspiration and maximal expiration. What they found out, the rate of change of lung area from maximum inspiration to maximum expiration, which is RS ratio, it was associated with RV over total lung capacity ratio in COPD patients, and it corresponds to the decrease in FEV1 level, which are seen in COPD as the air trapping is severe. So in severe air trapping, which is here, the RS ratio correspondingly decreased much more. So you have some kind of correlation for suggesting significant air trapping by these parameters comparing with the pulmonary function test. What about effect of treatment, bronchodilator? Here is the 53-year-old with the COPD. Before treatment, you can look at the lung areas, and after 3 months of bronchodilator, clearly the lung areas are better. They are expanding better. They are more increased expiration, so less residual volume, and you can plot them showing before treatment and after treatment. I think this is a very good modality to look at effectiveness of any treatment for asthma or any condition where you are trying to give bronchodilator and look at the effect. What about the VQ research? Again, this is very basic stuff. There are only few reports out there. This patient has a chronic pulmonary thromboembolism, okay? And these images are pre-thromboendarterectomy, and you can see a large filling defect on perfusion scintigraphy, what we do traditionally here, and there's a perfusion defect in the left lung. Similarly, on the DDR, you can see the color is low as compared to this, as well as here. Okay, and on angiography, because some institute, they still do pulmonary angiography before doing endarterectomy, you can look at decreased vascularity of the entire right lower lobe as well as left upper lobe part of it. So after thromboendarterectomy, we can see the basal portion, which was not perfused well, is now perfusing well on both sides, although left side is not, but right side definitely moved. But the perfusion on the upper lobe is actually decreased. This is basically a compensatory decreased flow because now blood is going predominantly to the lower lobes. And it corresponds with the DDR images as well as with the catheter angiography. So I think this may have a role in future. Remember, this is just from a chest radiograph. You can get all this information. This is a very fascinating case. Ventilation perfusion of a patient, 74-year-old with exertional dyspnea. If you just look at the radiograph, we don't have the radiograph, there was diffuse oligemia of the left lung, which can be subtle to detect, especially if you're not used to looking at the chest radiograph. But looking at these images of the vasculature or blood flow, you can see there is total absence of blood flow in the left lung. So traditionally, this will indicate that this is due to vascular occlusion. Commonly will be thrombus or embolus. It is not ventilation problem because there is no evidence of lung atelectasis. Lungs are perfusing well, or ventilation is good. In this case, it turned out this patient has a joint cell arthritis, and there was an aneurysmal dilatation and occlusion of the left lung pulmonary artery. So, a great case for demonstration. Probably has some utility. I'm not saying, you start doing, in suspected vasculitis DDR. No, but once this technique gets mature, we start looking at what can be the false positive or negative results with this technique. Once it gets mature, I think it has a lot of potential. Again, by looking at only DDR, radiograph, low cost, low exposure, you can get actually a bigger picture. Once you have this, you can target your further evaluation with limited cross-sectional imaging. So of course, you have a lot of other, you can play with these, all kind of joint. Again, a lot of potential in post-treatment or looking at the joints. Well, it's not going to show you. I didn't do it. It automatically switched over next. But there is a lot of potential for bones too. So DDR images provide more visibility by clearing the anatomy. It can quantify the motion of the diaphragm, and it can also provide some functional evaluation of the ventilation as well as perfusion. So in conclusion, we improve the visibility of the lung abnormality that make our confidence more accurate. It can provide evaluation of the diaphragm very well. We are going to replace with conventional fluoroscopy. The potential of functional data correlation with pulmonary function tests, I think it is huge in COPD, whether it's asthma or chronic bronchitis or emphysema. It can also have a potential useful in pandemic area where you cannot do PFTs, but you can get a broader picture of pulmonary function from DDR. Advanced computer analysis for ventilation and perfusions, once they are mature, they can be very useful. As I said before, currently workflow issue is there because it takes more time to process those images after the radiograph is done. And I am told that with the more, just like a computer, these are computer, new computer comes with a faster processing time, speed, and this time will be decreased with the newer versions. And I think that will help decreasing the negative impact on the busy practice. With that, I thank you very much for your time and attention.
If you have any questions, we have a microphone right here in the middle if you want to kind of step up and ask Dr. Singh. We still have a few minutes for a few questions. If you're too shy, I have some that came from the live stream. And so the first one that came is how is UAB communicating to the patient community that you're utilizing this new technology to help them?
Well, actually, we have not initially, because we were not sure what we are seeing. We can see the diaphragm. That's pretty much it. But slowly and slowly, we are realizing that this technique has a lot of potential. So we had a press release recently for public. I don't know how many people read those press releases. But we have not aggressively advertised this modality to public or even to our physicians yet. Because I'm sure once they see these images, especially the orthopedic doctors, they will want every patient to be done on that machine. And we have only one machine right now. So I am kind of biased for our lung imaging. So
Of course. Anybody in the room have any other questions? 'Cause I would like to ask, how would you promote this? I mean, this is a lot of information. How would you promote this to other attending physicians to help them understand that these capabilities are now available and help them with difficult cases?
well, we just have to talk to them and show them what it can do, which is going to take some time. Just like these, have small symposia and very limited focused talk. Okay, pulmonary function test. What you want information, we can try it, and then do a pilot short study comparing two different, techniques with DDR, and go from there. I think it's mainly the pulmonary medicine folks who will be interested, but in general, cardiothoracic surgeons will be very interested because they do see a lot of morbidity after the surgery. The chest wall dynamics is quite significant.
Anybody here any questions? Yes, please.
For the MSK applications, do you know if there's any plans to try to compare the data with bone models from CT scans to get 3D kinematics from the data?
So plans to make 3D. Yes, our first step is to find ways to find this type of metrics. And some joints, like the shoulder, is 3D. So we're working with some AI people to help us develop that. First, the tracking, movement tracking, motion tracking, stability tracking, and then evolve it to a 3D type of solution. Because as you can see, even with the lung, the image kind of gets that 3D sense. And because you have so many, it's a little easier, but it requires a lot of math and smart people to figure it out.
But this is a 2D imaging, So I don't know how you can get 3D information like we do from CT.
You get live planar systems, and then you can get 3D information. I can talk to you later.
Okay, okay.
Yeah,
as I
it's-
said,
it's-
there are a lot more smarter people who can do a lot of stuff.
So,
Good.
we have a system, and we can demo it at the Konica Minolta booth, but more importantly, this is not a sales approach. We think the clinical value of it is the value that we want to create, and that's why we're always willing to work with different approaches for research, and because you're teaching us what needs to be developed and drive the adoption. So it's focusing on the clinical value. And if there's no more questions, thank you for attending. Dr. Singh, thank you so much. We really appreciate your presence.
Thanks for this opportunity. I wanted to learn more, and this is the best way to learn once you have to deliver a talk, right? There's a hammer on your head. So, thank you.
Thank you.